The patient assessment, the airway. There are really two questions you must consider when assessing a patient's airway. Is the airway open, and will the airway stay open? See Table 9.1. Is the airway open? You can determine the presence of an airway in most patients by simply saying hello. The patient's ability to speak is an immediate indicator that he is capable of moving air. At the same time, a person who is unable to speak or one who speaks in an unusually raspy or hoarse voice may be indicating to you a difficulty moving air. Stridor is a high-pitched sound generated from partially obstructed airflow in the upper airway. This sound can be present on inhalation or exhalation, or both, and is an ominous sign of poor air management. The sound of breathing from the mouth and nose should be typically free from gurgling, gasping, crowing, wheezing, snoring, and stridor. You may also see patients use position to keep an airway open. When swelling obstructs airflow through the upper airway, typically due to infection, patients may present in the sniffing position. You will notice a bolt upright position with their head pitched forward as if they were attempting to smell something. In a person with a partially obstructed airway, this position can be critical to keeping air moving. Stridor, a high-pitched sound generated from partially obstructed airflow in the upper airway. Often, it is not immediately apparent if an airway is present. In your CPR class, you may have learned about the look, listen, feel method. If a person is unconscious, you may need to employ this method to ensure an airway is present. In this case, look at the chest to see if it is rising and falling. The airway should also be visually inspected for foreign bodies, including objects and fluid. You should listen at the mouth for sounds of breathing while placing your hand on the chest to feel for movement. You may also need to place your hand near the patient's mouth to feel for airflow. In these cases, you may detect subtle air movement that might not be apparent with just visual observation. Remember that you assess the airway as part of the primary assessment, and when you find a problem in the primary assessment, you must stop and fix that problem. In this case, if there is no airway present, stop and provide one. We will discuss airway treatment later in this chapter. Will the airway stay open? The first part of this chapter discussed ensuring an open airway. That is certainly important, but of equal importance now will be ensuring that the airway stays open. Airway assessment is not just a moment in time, but rather a constant consideration, especially in a critical patient. In some cases, you may need to immediately consider how to keep an airway open after initially establishing it. In a person with no ability to keep an airway open, you may manually open it with a head tilt, chin lift. However, the moment you take your hands away, that airway will be lost. At this point, you must consider additional steps. Similarly, if you identify a partially obstructed airway, you must ask yourself, how long will it be until this airway is completely obstructed? And what are the necessary steps to take to prevent or resolve this problem? Consider the following examples. You assess the airway of an unconscious victim of a fall off of a ladder. He has no airway, so you apply the jaw thrust. The airway opens and he begins to breathe. However, when you take your hands away, the airway closes and he stops breathing. In this case, the airway is open, but will not stay open. You assess a child after multiple bee stings. He speaks to you with a hoarse voice, but is breathing. You note stridor on aspiration. He has an airway, but his voice changes indicate that his airway is swelling and partially obstructing air movement. How long will he be able to move air? What steps must you take immediately to keep air moving? Remember also that the ability to maintain an airway can change over time. As mental status decreases, so might the ability to protect an airway. Always reassess this capability, and remember that just because your patient has an open airway now, there's no guarantee he will continue to have an open airway later. Okay, going back to table 9.1. The airway in the primary assessment, ABC. Is the airway open? Is the patient able to speak? Look. Visually inspect the airway to ensure it is free from foreign bodies and obvious trauma. Look for visual signs of breathing, such as chest rising. Listen. Listen for the sound of breathing. Listen for the sounds of obstructed air movement, such as stridor, snoring, gurgling, and gasping. Feel. Feel for air movement at the mouth. Feel the chest for rise and fall. Will the airway stay open? Are there immediate correctable threats? If no airway, then open it. Consider how you might keep open an unstable airway. Consider ALS for more definitive airway care. Are there potential threats that may develop later? Reassess, reassess, reassess. Assess for signs of impending collapse, such as stridor or voice changes. Consider conditions that may later threaten the airway, such as anaphylaxis. Anaphylaxis is usually caused by an allergic reaction, like in a bee sting or somebody who has like a crazy nut allergy, and it often involves inflammation. I'm just telling you this because I know it. Signs of an inadequate airway. Signs that would indicate no airway or a potentially inadequate airway include the following. There are no signs of breathing or air movement. There is evidence of foreign bodies in the airway, including blood, vomit, or objects such as broken teeth. No air can be felt or heard at the nose or mouth, or the amount of air exchanged is below normal. The patient is unable to speak or has difficulty speaking. The patient has an unusual hoarse or raspy quality to his voice. Chest movements are absent, minimal, or uneven. Movement associated with breathing is limited to the abdomen, abdominal breathing. Breath sounds are diminished or absent. Noises such as wheezing, crowing, stridor, snoring, gurgling, or gasping are heard during breathing. In children, there may be retractions, a pulling in of the muscles above the clavicles and between and below the ribs. Nasal flaring, widening of the nostrils of the nose with respirations may be present, especially in infants and children. Critical decision making. Will the airway stay open? You have learned about signs of an unstable airway. Use this information to consider whether the following patients have an airway that will stay open. 1. A 16-year-old asthma patient who tells you he is tired and seems to be nodding off to sleep. A 72-year-old female who was recently diagnosed with pneumonia. Today she has called you because her breathing is much worse. She is breathing rapidly and has diminished lung sounds on the left side. A 35-year-old male who tells you he is having trouble breathing. You notice he is drooling and is sitting bolt upright. When you attempt to lean him back on the stretcher, he coughs, gags, and repositions himself in a sniffing position. A 16-month-old whose mother tells you the child has had a cold for 2 days and woke up with a cough tonight. The child is awake and alert, but barking like a seal when she coughs.